So I know the CCF focuses on funding researchers, physician scientists in the Baltimore, Washington area, but this year CCF has gone outside the area, given we are all good and used to the Zoom virtual meetings. And for the first time, they have invited an outside speaker for a very good reason. So it is my honor and pleasure to introduce Dr. Stephan Grupp, which many of us are very familiar with and who does not need much introduction. He is at Children's Hospital of Philadelphia as a section chief of the Cellular Therapy and Transplant section and the director of the Cancer Therapy Program and the medical director of the Cell and Gene Therapy Laboratory. He received his MD Ph.D. from Cincinnati and then completed his training at Harvard Medical School, Boston Children's in Dana-Farber before coming to CHOP in 1996. And he has been a pioneer for CAR T-cell therapies, and we are fortunate that this living drug is now commercially available for a lot of our patients, thanks to his and his team's effort at CHOP. And with further ado, Dr. Grupp, I think you're on.
Goal not to put people to sleep, so hopefully that'll be the case. And here we go with some slides, so even better. So in the next 15 minutes, I was asked to talk to the group about cell therapy in practice. And, you know, for those of you who have used CAR Ts, some of this stuff will be kind of CAR T 101. I hope it's useful nonetheless. And this really represents the approach that we've developed to CAR T since the first patient that we treated back in April of 2012. And this includes the approaches to toxicity management, which are so important to actually successfully using these therapies. And so, next slide. Here are my disclosures. The only one relevant to this talk is that I received trial support and research support from Novartis and also consult for them. Next slide. So, forgive me if this is a review, but just so we're all level setting here, what a chimeric antigen receptor, or CAR, is. So hopefully you can see my pointer, but what we're looking at on the top is a cancer cell, in this particular instance an ALL, or it could be a lymphoma cell, that's CD19 positive, which is the target that we chose for the first CAR Ts. There's some good reasons for that target, and one of them is that the only other cell in the body that expresses CD19 is normal B cells, which are a bystander to this CAR T cell process and are destroyed by CAR T cells, because we can't tell the difference between a leukemic B cell and a normal B cell. On the T cell side, we have this artificial molecule, which includes a single chain FV antibody, which actually recognizes CD19. So anything you have a monoclonal antibody for, we can make a CAR to fairly quickly. And on the inside, without getting too immunologic about it, we have the various parts of the T cell activation machinery: CD3 zeta for the initial signal, CD28 for the co-stimulatory signal in another form of CAR T that's not ours, and then 4-1BB as the co-stimulatory signal that we use. So we aren't using both. We're just using 4-1BB. Right now, with the commercial therapy, the U.S. indications are refractory ALL, defined however you want, second relapse, and doesn't include automatic eligibility for post-transplant relapse, although that was part of the clinical trials. And patients have to be 25 or less, and that's actually non-negotiable in an interesting way, because the drug company knows something about the identity of your patient, and they know the age. So they will not make a product for a 26-year-old. So it's not one of those things you can do off-label. Next slide. So this is data that is due to be updated from the Eliana International Registration Trial. This was a trial that basically came out of the CHOP Pen development process for CTL019, which led to a multi-site trial, which led to this Novartis-sponsored registration trial, which I was privileged to run the study steering committee for. And that was an interesting experience for me because, as my wife will tell you, I was essentially on call 24/7 for 2.5 years straight to what was effectively the entire planet, because this was 25 centers in 11 countries across both the Atlantic and Pacific Oceans. So this was really a study with international logistics and international reach. Um, our goal was to show what the CR rate was after CAR T cell therapy and get close to the single center results around 90%, and we did with a CR/CRI rate of 82%. And then we also looked at flow MRD and showed that almost all of these patients were MRD negative, so they were reasonably deep remissions, although we have better technology for that now. Next. I think once you get into remission, the question is, do you stay there? And so this is the relapse-free survival rate among patients who responded, that 82%. And so 66% at 12 months and then 62% at 24 months. And we're due for an update for these data, which should be out in the next 6 months or so. And then overall survival as shown, which isn't that different, especially at that time when we were running this trial. We were really the last stop on the train, and so there wasn't that much that folks could do for patients that either didn't respond or that relapsed, especially with CD19 negative disease. Next slide. Now, the main toxicity, as all of you are aware, is this thing called cytokine release syndrome. And it was a big deal trying to figure this out. And we had to actually figure this out on the fly with the first patient that we treated, a little girl named Emily Whitehead, who is now a 16-year-old about to get her driver's license. This syndrome doesn't happen in all patients, but it can go from fever and myalgias and feeling generally miserable to severe ICU level care, but reversible toxicities, including hypotension and ARDS. Next slide. Now, the reason why we're able to talk about this is that we figured out mechanistically what was going on in this first patient and then confirmed it in the following patients. And so this is from our second New England Journal paper where we looked at ferritin as a marker of macrophage activation syndrome, or HLH. And this actually came from an observation by Dave Tichy at CHOP, who looked at our first patients and said, hey, you ought to be measuring ferritins in these patients because this really looks like MAS or HLH. And sure enough, we were seeing ferritins in the 10,000 to 500,000 range. And as you can see on this graph indicating no, they didn't go to the ICU, or yes, they did, that the ferritins were 100-fold higher in patients who did go to the ICU. And so this is an indication that CRS is a macrophage activation syndrome. Next. The other key observation, as I'm sure many are familiar with, was that interleukin-6 is also 100-fold higher in patients with ICU-level symptoms. And this, we actually observed this in our first patient. And again, one night when we thought that she wasn't going to survive severe CRS, gave her the IL-6 blocking drug tocilizumab, which turned around her life-threatening CRS overnight. And so this was a surprise to us because IL-6 isn't even made by T cells. You see interferon gamma, that's an effector cytokine. It's also 100-fold higher in patients with ICU-level symptoms. And that's because in order for the T cell to control large leukemia burdens, they have to grow to very large levels. And then there's a concomitant generalized activation of the immune system. Next slide. People ask quite frequently, what about, who needs this to get this sick? Maybe we can prevent patients from getting sick. So we just published a trial in JCO about a month or so ago, actually a couple months now, testing the preemptive use of this drug tocilizumab, which blocks the IL-6 receptor in patients with high disease burden, because of the observation that the number one reason you get sick is high disease burden, by far. It swamps everything else. And so we defined high disease burden based on our prior experience at 40% blasts or more. And Our plan was to give a single dose of tocilizumab at the moment that they developed the fever. So that was a preemptive and not a prophylactic approach. And our goal was to reduce grade 4 CRS. And then we treated all the patients the same. Next slide. And data from that trial show a best overall response rate of 97%. So obviously we were pleased about that, although efficacy was not the primary endpoint. Differences, although modest but real, between the high tumor burden cohort, 87% CR, versus the low tumor burden cohort at 100% CR. And that included patients who we were determining their tumor burden after lymphodepleting chemotherapy and right before we gave the CAR T cells. And so some of those patients were already in CR from their lymphodepleting chemotherapy. So 100% isn't as good as it sounds, but 87% in a group of refractory ALL patients is pretty good. Our study endpoint was we wanted less than 5 out of 15 high tumor burden patients with grade 4 CRS, which would have been about half what we would have expected historically, and we met that endpoint with 4 out of 15. So reduction, substantial reduction, not elimination of grade 4 CRS. Very important to point that out. But the key thing is, in addition to it working, is it didn't impact the CR rate. It didn't impact CAR T cell expansion, so early tocilizumab didn't interfere with the CAR expansion. You think maybe it might interfere with long-term persistence. It doesn't. And people worry that it interferes with neurotoxicity or ICANS because of observations made early in the KITE trials and was not observed at all for us. Next slide. And this is just some of the data showing overall survival that's quite good, but light blue is the low tumor burden cohort and then orange is the high tumor. So you really see a statistically significant difference between the two cohorts. So high tumor burden affects the toxicity very much. It affects the ability to go into remission modestly, and it affects the ability to maintain a remission as well. In addition, we can see that the B-cell aplasia, a little around 50% or better, was similar across both cohorts, showing that we were able to maintain persistence perfectly fine in high tumor burden patients. Seattle has noted that low tumor burden patients don't maintain their persistence, but we have not noticed that, and you don't see that in these data. It's not what we see at all. So maybe some differences between their CAR T product and our CAR T product. Next slide. Now this part I find very interesting. So this seems like heresy, although less heresy than it was previously. But we give all our patients, our CAR T patients, their CAR T cells in the outpatient clinic. We don't admit them to the hospital. We don't keep them in the hospital. We don't put them in the ICU. We just give it to them in the clinic like platelets. Except for the big difference is that it takes way less longer way less time than platelets. It takes about 1 or 2 minutes to give the CAR T infusion. It's actually very disappointing to families, just like transplants are. That's all there is to it. But of course, all the high-tech stuff is in the manufacturing. So 95% of our patients get their CAR T cells in an outpatient setting. And then we wait to admit them for fever. So the first step in CRS is always fever. So if they get a fever at 2 o'clock in the morning, they're a leukemia patient with a central line with febrile neutropenia. These families know how to deal with this. They come to the ED. They get admitted to the hospital. Now, in the ED, you manage them like a febrile neutropenia patient. You don't treat their CRS. All right, that happens on the floor and later. The physician in the ED does not need to know how to manage CRS. They just need to know how to manage FNN, and they do know how to do that. So if you see over time, from the beginning of our program in 2012 to 2019, you can see the steady decrease in admission, that's the blue line, and ICU level care, which is the red line. So now we're putting 12% of our patients in the ICU, and half our patients are never admitted to the hospital at all. And a lot of this has to do with the fact that we're treating patients who are less refractory, who have less higher disease burden, and who are less sick to start with. Next slide. Oh, this is just the stats. I forgot I had that on there. So this is also matched in the real world data. So the CIBMTR has been collecting data across both the lymphoma indication and the ALL indication. And if you look in that box, if you can see it on your screen, In the Eliana trial, grade 3 and 4 CRS was 48%. Almost half the patients had grade 3 or 4 CRS, which lands you in the ICU, whereas now it's 16% in the CIBM-TR data and 12% for us. So this has gotten much better. It's still very hectic. The sickest patients are still as sick as they ever were. There are just far fewer of them. And our ICU wonders if we've forgotten about them because they don't see us as nearly as often as they used to 5 years ago. Next slide. We're trying to get everybody, this is an exercise in herding cats, but we're trying to get everybody on the same page, trying to get consensus grading across trials, commercial products, across companies, and across universities. It ain't easy, but we've done it. So there is a consensus grading criteria for both CRS and ICANS, and we're also trying to develop consensus approaches to controlling adverse events beyond CRS. Next slide. We can talk about this with the questions, but basically our goal is not to transplant most patients who receive CAR T, and so 80% plus of our patients at CHOP don't go to BMT routinely after our treatments. There are patients who do. If they're MRD positive at day 28, that's a concern. We take them to transplant. Early B-cell recovery, you either give them CAR T cells again or you take them to transplant. If they get CAR T, relapse, get CAR T again, go back into remission, got to really think about transplant in those patients. And then we argue endlessly about MLL rearranged patients. Next slide. Want to briefly comment on the fact that now we're moving on to other engineered cell therapies. And, you know, it's interesting, as a transplanter now and not a cell therapist, those two worlds are coming together beautifully because half of the unrelated donor transplants that we do at CHOP are for non-malignant diseases, even though we're firmly in the oncology group. Our first shot on goal here is very much the hemoglobinopathy trials with thalassemia and sickle cell. And this is just data, or at least a recognition of presentations at ASH and concurrently in the New England Journal about the gene editing approach of CRISPR-Cas9 to increase fetal hemoglobin. And this has prevented transfusions in all the thal patients treated to date and ended VOCs for all of the sickle cell patients treated. And although it's early days and a smaller number of patients, it looks promising, but we need further follow-up. But this is something that we're now learning from the CAR T field about how to do engineered cell therapy and moving it into non-cancer diagnoses, which is very exciting. Next slide. I already said that. Next slide. So I just want to end just acknowledging all the many people involved in this, CHOP and Penn, this great cell therapy opportunities there. Carl June running the program at Penn and my long-term collaborator for 20 years. Our cell therapy lab, including Dave Tichy, who has made so many observations within these CRS patients. The actual manufacturing folks at CVPF at Penn and others as well, including Shannon Maud and our clinical group. And so with that, very quick, hopefully non-sleepy introduction to CAR T. I'd be happy to take any questions.
Thank you, Dr. Tichy. Dr. Tichy, I was thinking of him. Sorry about that. Thank you, Dr. Grupp, for your presentation.
You said that.
While we're waiting for questions, anyone?
Bring him back on.
Yeah, it seems like.
Oh, that's us.
Are you there?
There he
Dr.
is.
Grupp? Yep.
Yeah, I'm here. I didn't go anywhere.
Awesome. All right. So thank you for that presentation. Any questions from the group while we're waiting for questions from the other side? I do have one question for you. We've heard, that there is good efficacy and good penetration in the extramedullary sites of the CAR T cells. Do you think we are there to move it forward, that we could eliminate radiation for CNS relapses, especially the isolated CNS relapses?
So that's a fantastic question. So I didn't get into that, but we've treated a large number of patients with CNS disease. Initially CNS2, not at diagnosis, CNS2 at infusion. So, and we've seen the CAR T cells clear that. Then CNS3, then CNS parenchymal disease. We've treated patients with CNS cranial nerve involvement. And so we know that we can do this safely. There is some increase in neurotoxicity, but it's not unsafe by any means. And we see excellent efficacy with almost all of these patients going into remission. So we know the CAR T cells go to the CSF and the CNS, and we know they can control disease, and our overall CNS relapse rate with no CNS prophylaxis after CAR T. By the way, that means no ITs after CAR T. The CAR T cells are in the CSF. Why would you put methotrexate in there and kill them? So we don't do that. And what we do is we just watch these kids, and we have less than a 2% CNS relapse rate. So yes, I think we have a clinical trial at CHOP right now testing that very question, CNS relapse without radiation, without transplant, see if we can actually put these kids in remission and keep them there without some of the toxicities. It's a great question.
Great, thank you. Yes.
Hey, Steve, I don't know if you can see us, but we can see you. Thank you so much for joining today to be part of this symposia. I guess this is one of the nice perks about the kind of technology that's developed over COVID, is that you get to sit in your office and we get to have you part of a symposia here in Maryland. So I was going to ask you, so, you know, there are relapses and it's not 100%. And, you know, just in the same way that we're struggling in Ewing sarcoma with targeting EWS-FLI and why we're not seeing 100% response or sustained. And the question is here too. What do you think is driving the relapses, and what do you see on the horizon to go for that next sort of level of improvement beyond what you've got now?
Yes. I think that there are two parts to that. One is, can we improve on a 97% response rate? Obviously in a CHOP trial and not a multi-institutional trial. I'm not sure there's a lot we can do to that, partially because when a patient doesn't respond, it means that their T cells aren't working at all. And right now we don't have manufacturing techniques to fix broken T cells, although we may have that in the future. But I couldn't say I could point you to one technology that would actually get us there. But the issue is relapse. So if we're looking at 50-60% for longish term, let's say 5 year, although we haven't published data that far out yet, but let's say 50-ish% 5 year relapse-free survival in patients who go into remission. All of that, none of that is toxicity. All of it is relapse. Most of it is CD19 escape. So I think that it's teaching us that you need more than one target. Even in ALL, the optimized disease for cell therapy, and CD19, the optimized target for cell therapy, it's still an issue, which will even be more of an issue in solid tumors, that we need more than one target. And so we and several other groups are testing combination 1922 CD22 therapy, since 90% of ALL is CD22 positive, as a way of changing that, let's say 3-year RFS from 60% to 80%. So that's being tested multiple places, but you need both things. You need persistence in ALL. In lymphoma, there's an argument whether you need persistence, but in ALL, I really do believe you need persistence, and then you need dual targeting. You need both those things.
Thank you. So sort of building off those two previous questions, and this one is simple, but when talking about using CAR Ts for CNS disease and the importance of persistence, do you see differences in persistence of CAR Ts, whether in the CSF or in circulation?
That's a great question, and the answer is we don't really know. And why do we not really know? Because we stopped looking. So out to a year, every single patient who, 98% of patients who have detectable CAR Ts in the marrow and blood have detectable CAR Ts in the CSF. I don't know elsewhere in the CNS, but I know it's in the CSF because that's our last spinal tap is at month 12. So beyond that, we have no idea. We don't know if they persist as long. So out to a year, they definitely persist just as long. Beyond a year, we can access the blood, but we're no longer doing procedures on these patients, and so we don't know.
Thank you for that talk, Dr. Grupp. I went to the Silicon Valley meeting a couple of years ago up at Penn, and there was some speculation at that time that CD19 may be expressed on pericytes, and that may be the mechanism of action of the neurologic, side effects. Is that an observation that's been borne out, or is the mechanism still unknown?
Yeah, Carl June is going to kill me, but I didn't buy it at the time, and I don't buy it now. And if he heard me, that would be the end of everything. But seriously, other people get CNS toxicity from CAR Ts other than those who receive a CNS CAR T, CD19 CAR T. So my sense is that it's not only CD19. That data, I mean, they tried as hard as they could to show whether that was true or not. It's still possible that that's the mechanism of action. I personally think that it's cytokine related, but we don't all honestly know. And we know for sure that the cells are up there, so that if there is a target, that you would see that. But it doesn't explain neurotoxicity with a BCMA CAR, for example.
Steve, it's Pat Brown. Backing that up is the blinatumomab rates of neurotoxicity with blinatumomab are essentially the same as with CAR T, and yet blinatumomab it notoriously doesn't penetrate the CNS, and that is why CAR T is so much more effective in CNS, but the neurotoxicity rates are the same, and that would argue very strongly against a direct parasite effect, but for more of a cytokine-mediated effect, because when blinatumomab works, the cytokine levels are just as they are in CAR T. So not a question for you, Steve. Great talk, but part of an answer.
I love that answer, so I'm going to go with that. Thanks, Pat.
Thank you, Dr. Grupp, and I'm glad you were able to join us today. And we'll move on to our next session now.